I'm Dr. William Suh. I'm an interventional cardiologist at Ronald Reagan UCLA Medical Center. So at the ACC meeting this year, the 2-year data from the CoreValve US pivotal trial was presented, and the results were very exciting. The 1-year data showed that there was a mortality benefit with CoreValve versus conventional open heart surgery, and at 2 years that benefit was still seen. So high surgical risk was defined by evaluation by 2 cardiac surgeons as well as an interventional cardiologist, and they had to deem a patient to be high risk, meaning that they had a greater than 15% chance of mortality at 30 days after an open heart surgery. There are certain states that do require public reporting for percutaneous coronary interventions. Those states include Massachusetts and New York. At the moment, California is not a publicly reporting state. In the future, that may become the case, and maybe interventional cardiologists will become more reluctant to take on high-risk cases. But these are patients that are at high surgical risk, have no other options, and with a successful procedure, they can live a normal life. So the 1-year mortality data showed that there was an absolute difference in mortality of 4.8% at the 1-year mark. And at the ACC meeting this past year, the 2-year data shows that the absolute difference in mortality actually improved to 6.5%. So the Kaplan-Meier survival curves there actually did diverge a little bit more. So the benefit was sustained. Two potential reasons why the SAPIEN data doesn't appear as well as the CoreValve data. One is that the patient populations were inherently different. So if you take a look at the STS score, the Society of Thoracic Surgeons have a risk model for predicting the risk of mortality. The STS score was pretty different between the 2 groups. So the partner trial, the STS score mean was 11%, whereas in the CoreValve trial, the mean STS score was 7%. So you can say that because the CoreValve was a lower risk patient population, that may be the reason why they saw a better survival in that patient cohort. Another reason why CoreValve may have performed better, at least with regards to paravalvular regurgitation, is that CT scans were actually used as a gold standard for measuring the aortic annulus. And we know that when we properly measure the aortic annulus and get a good 10%, at least 10% oversizing on the aortic annulus, paravalvular regurgitation is minimized. So we do see some strokes, even out to 1 to 2 years. Most of the strokes occur around the procedure time, but we have seen increased stroke throughout the follow-up period. That may be due to an increased incidence of atrial fibrillation in this patient population. We don't know what the optimum anticoagulation regimen should be for our TAVR patients, so that's something that still needs to be worked out. There also is an increased risk of complete heart block with both devices. You can see that also in the follow-up period. It was more in the CoreValve arm or CoreValve group, since the CoreValve device actually sits lower in the left ventricular outflow tract, which puts more compression on the conduction system of the heart. Yeah, once the device is implanted and we don't have any migration at the time of the procedure, there has been no reported device embolizations in follow-up. Yeah, in the CoreValve study, the surgical group actually had a higher risk of stroke. There was a 9.8% risk of stroke in the surgical arm versus a 6.8% risk of stroke in the TAVR arm. So probably due to the lower profile of the CoreValve device that they saw less stroke compared to previous studies. So carotid filters would be a great idea. They are starting to be looked at in Europe in clinical trials. At the current moment, we do not have any FDA-approved devices for carotid embolization protection. That's a good question. You know, from a safety standpoint, these things probably could be developed concurrently, but the limitations of the FDA and getting device approval sometimes is a challenge. So it was very exciting that the CoreValve study showed a superiority in terms of mortality versus conventional open heart surgery. It's just one trial data to suggest that we are maybe going to see a shift in recommendations towards TAVR. But at the moment, for lower risk patients, the gold standard is still surgery. With that in mind, though, at the ACC, the SAPIEN 3 data, which is the balloon expandable Edwards device, they presented their 30-day data, and it's also very promising that they are able to perform TAVR in a lower risk patient population with excellent outcomes. So the design of the SAPIEN 3 device is different than the CoreValve device. The CoreValve is made from a nitinol frame, whereas the SAPIEN 3 device is cobalt chromium alloy as the stent type. The main difference with the SAPIEN 3 device compared to all other devices currently available is that there's an outer skirt on the outside of the stent that actually will help capture paravalvular leak. And so moderate to severe paravalvular regurgitation is almost non-existent in the SAPIEN 3 device.